working as the Assistant Professor of Medicine in the Mayo Clinic College of Medicine and Science. He is also the Vice Chair of the Department of Medicine, AI, and Innovation, Chair of Innovation, Division of Hospital Internal Medicine, and a consultant with the Division of Hospital Internal Medicine. Welcome, Dr. Ryu.
Awesome. Well, thanks everyone for sticking around to the end of the day here, and thank you, Penny and team, for hosting me. This has been a super inspiring symposium. I've definitely learned a lot, and I think it's really incredible the innovative work that you all are doing. And for the residents in the room, it's worth noting that at most places you can't just work directly with your hospital's director of data analytics, so that's pretty special. So to wrap up the day here, I'm going to talk a little bit about 7 ways that AI can transform your practice. Some of the examples that I think are the most exciting, some things that we're doing at Mayo Clinic, and hopefully spur some new ideas for you as well as you embark on the different work that you're doing. So for the first example here, how many of the clinicians in the room can relate to just feeling overburdened with documentation, whether this is things like clinical notes, discharge summaries, admission H&Ps, whatever that may be, and feel like that's ultimately driving burnout, taking your time away from focusing on patients, and it's a problem that just seems to be getting worse and worse with no solution in sight. But the good news there is that, of course, there is now technology that can change that paradigm for all of us, and this is something that we're eagerly embracing at Mayo Clinic, and that's ambient dictation. Of course, we wouldn't make it through 7 examples without covering this. But now we, of course, have AI solutions that can listen to our patient interactions, convert those into different types of documentation. And this is well within kind of the capabilities of latest generation LLMs. And so this is obviously an exciting area. And we've seen both opportunities and challenges around this at Mayo Clinic. So, of course, I think the pitch for these is they can save time, they can lessen burnout for clinicians. We've heard a lot of positive anecdotes about these. I think probably the most striking one that I've heard sort of second or third hand was, this ambient dictation tool saved my marriage, which, I can't speak to the validity of that, but people, have strong feelings about these without a doubt. And certainly this is well within the realm of what we can do with latest generation LLMs. But there are other considerations too that we're noticing as we roll these out across our practices, which is that there are coding, billing implications of the notes that get generated by these solutions, and sometimes in efforts to make notes patient-friendly, then they become payer-unfriendly. And so you may have negative impacts to reimbursement or to risk coding. And that's something that we're sorting through in real time now. I think for anyone that's concerned about sort of bottom line financial impacts too, I think the verdict is still out on whether these actually, lead to more patient visits, save costs, things like that. And I'll cover a study that kind of goes through some of that in a subsequent slide. But I think just to kind of also illustrate some of the nuances here, I'm a hospitalist, and for me, generally, patient notes are not really the most time-consuming part of my day or a limiting factor in terms of my workflow. So it's something that for our outpatient staff, they've really eagerly embraced and are excited about. Something that for me and a lot of my colleagues, we are in a later wave of rollout, and we're totally fine with that. On the other hand, I've also run into colleagues in very niche subspecialties. For instance, a subspecialist peripheral neurologist who actually stopped me as we were walking into work one day to ask me, hey, are you involved with this ambient dictation stuff? And knowing that he's a guy who's not afraid to speak his mind, I hedged a little bit and I was like, well, I know some things about it. I'm sort of involved. And then the next thing I know, he's sort of going on a tirade about how it doesn't capture nearly the amount of detail that he needs for his visits. It's actually just added to his workload, and he was really, unfortunately, dissatisfied with the solution that we initially had. And that's actually driven us to embrace two solutions for ambient dictation, kind of to meet different people's workflow needs. So, probably many of you have also seen this study that came out recently at Kaiser Permanente, where they did a large scale evaluation of um, ambient dictation tools, which impressively captured 63,000 patient encounters, had a decent survey response rate, a bunch of free text comments as well. But I think it's also worth noting that a lot of the evaluation here was really clinicians rating their own work, essentially, or rating the outputs that they were given in their everyday workflow. And I think that begs the question, is that really the most rigorous way to evaluate something like this? Which I would say, in kind of a strictly academic sense, oftentimes these quality evaluations will be done offline by a group who's just tasked with evaluating AI outputs rather than asking people to do this in the middle of their workday. Um, and additionally, I think getting to the level of actual time savings picked up on the back end of IT systems or actual financial impacts, is still yet to be seen, even from large scale analyses like this. So, moving on to the second example, how many people can relate to seeing a clinic schedule like this and just wondering how will you get caught up with the patients that you need to be seeing that day? Or maybe your hospital patient list and thinking through how do I get up to speed with 20, 25 patients on a Monday as you're coming onto service or whatever day you do switch. And wouldn't it be great if there's a way to remove the redundancy in documentation, get kind of a synthesized summary of what's going on for patients and be able to sort of sift through that in a much more streamlined way? And of course, there are solutions for that as well. So, large language models are through a number of different products being rolled out to summarize patient charts for a lot of different use cases. But this is another exciting opportunity, I think, to streamline some of these historical headaches that we've had. And just as was highlighted earlier, sift through things like redundant documentation and all the noise that comes with that. So, looking at some of the opportunities and challenges in this space, um, obviously there's an opportunity to automate manual workflows, not just the things that we're doing in our everyday practice, but for research as well. So, I think for many residents, if you're not familiar yet, you probably will be with doing chart reviews of tens, hundreds of patients, going back through their records, trying to ascertain nuances from clinical documentation. But obviously, there are ways to do that now with large language models, feeding notes through those, asking targeted questions so that you don't have to actually go back and do all of that yourself. And maybe you can just do some limited validation of what you're getting back. We've also seen a proliferation of use tools for this use case. So whether these are things that are coming from EHR vendors for things like discharge summaries, interval summaries for inpatient stays, things for handoffs, um, no shortage of tools that are coming along to enable these types of use cases. But there's still challenge with things like eliminating hallucinations or figuring out how to actually make sure that you're presenting a complete picture of patient data without missing important details. And a lot of these tools rely on a framework called RAG, or retrieval augmented generation, which, if you're kind of in the large language model space, you know that this relies on a search step where you're essentially grabbing what model thinks are the relevant notes for a query that you've asked and then feeding that in through a large language model prompt. But you can imagine if you don't grab the right notes in this first search step, you'll be missing important information or you may have incorrect information later on. So one example of that I've seen, using tools like this and also building them is, confusing a description of maybe an echo report in a progress note with the actual echo report itself. And I think for clinicians, we know that we need that actual ground truth to refer to, make sure that we have all the details that are mentioned there. whereas simple nuances like that will actually get missed by tools built on this type of framework. So some highlights from Mayo Clinic is that we are actually piloting multiple summarization tools for various use cases, both things that we've developed internally and things that we've purchased from vendors. As I mentioned, many of these do rely on RAG frameworks, and that comes with different risks as well. Something we quickly learned is that summaries are also extremely purpose specific. So the summary that a neurosurgeon wants is going to be different than what an internist wants or a palliative care physician. The summary that's suitable for a discharge is different than a overnight event summary. And so all of those require different engineering, different data science processes, different validation as well, which is often quite challenging. For anyone who's ever participated in one of these LLM evaluation studies, I think you can appreciate that trying to do things like rating a clinical note, is this 10 out of 10 for concision or a 9 out of 10? I don't know that we could get anyone to necessarily agree on what those definitions are. And, going through 10, 20, 50 of these can get mind numbing pretty quickly. And so it's just a real challenge and an expensive one to have these rigorously clinically validated. We've also seen that unintended use is pretty common. A good friend of mine sort of is in charge of rolling out Epic's generative AI tools at our institution. And as soon as he rolled out a discharge summary tool, he immediately started getting phone calls of, your discharge summary tool doesn't work for my shift handoffs, and please go back and fix that. And in fact, that's just really unintended use of a tool. Again, getting to the notion that summaries have to be very use case specific. But still, I think there's a lot of opportunity here, but will come down to engineering and validating solutions robustly and also ensuring that they're used correctly. So, moving on to another paradigm here. As clinicians, we often learn from the patients that we've seen, whether that's in medical school or residency or out in clinical practice. And sort of our knowledge and frame of reference is based on, that firsthand experience or maybe some cases that you've discussed with your colleagues as well. But what if instead you could learn from entire populations of patients, including ones that you've never seen that maybe haven't even been seen at your institution? And this is a trend that is really emerging right now with large data sets that are combined across different healthcare institutions, whether those are regionally, whether those are by EHR vendors or by organizations like Mayo Clinic Platform as well. And so there's huge opportunities in this to derive insights from entire patient populations. And that's really been driven by computing infrastructure and data standards that allow us to pool together data like we never have been able to before. And this really holds the promise of being able to realize personalized medicine in the ways that I think we've envisioned for a long time, actually being able to understand what's the best treatment for a patient beyond just what's listed in guidelines for them. But there are a number of challenges that come with this as well. So just being able to suggest what are the right patients to compare against for the patient that you're seeing. There's still obviously specific use cases. What is the interface for that going to look like? How are you going to interact with a tool like this that I think have yet to be defined? And then there are, of course, concerns depending on the specific arrangement that you might be entering into with data ownership, data sharing, privacy agreements, things like that. So to just cover two examples, of course, Mayo Clinic Platform runs one of these data networks, and so aggregates over 50 million patients across 8 global medical centers, and it is sort of poised to provide those kind of insights that you might be able to not see any other way, whether it's for rare diseases, rare demographics, things like that. Epic also runs one called Cosmos, but there are a number of other examples of this too, and it doesn't necessarily need to be multi-institution. Even just ability to aggregate data across hospitals or clinics within your own network or within your own region are opportunities to make progress against these kind of goals as well. I think to highlight the challenges with this too, there was a tool announced, I believe, close to 3 years ago now from Epic called Best Care for My Patient, which was purported to do exactly this, um, providing insights from comparable patients to the one that you're seeing. And 2 years later, we're still waiting to kind of see exactly what that will look like in its first prototype form. And I'm certain that they are making progress on it, but I think it's no small challenge to really try and distill that to, yes, you have access to all of these patients, but for a clinician actually sitting down and doing a visit, there's a lot that has to go between all of that data and actually an insight that you can act on. So, speaking of insights that you can act on, obviously, a lot of what we do as clinicians is evaluate patients, run diagnostic tests, conduct physical exams, things like that. And we've been doing that obviously for a very long time in ways that are arguably pretty outdated. Um, and so we're now at a time where instead of just using things like stethoscopes and otoscopes, we can actually take all of a patient's data, whether that's labs, notes, imaging studies, pathology images, run those through multimodal AI models and get insights about what is the best diagnosis or treatment plan for this patient. And we're doing some pretty exciting work with this with a company called Cerebras, a GPU company, around making genomic transformer models. So basically, you can take a patient's raw exome sequence, feed it into an AI model, and understand new things about what might be the best treatment course for them. And I'll share some details on that. So we're obviously at a point now where, because of breakthroughs like this, medical diagnosis and treatment can be informed by more data than it ever has been before. But of course, that presents new challenges too. Transformer models obviously have redefined state of the art across many different domains, whether that's text. These are the transformers are the models that power large LLMs. They also power things like vision transformers for image based tasks and a variety of other things, like converting speech to text. But doing things like working in these spaces is expensive. If you're looking to actually train a foundational model from scratch, it's probably a minimum of $5 to $10 million. 6 million was the GPU rental cost quoted in the DeepSeek paper recently, and obviously there's a lot more that goes into training a model than just the GPU rental. And I think the business models to support this are still emerging. So we've seen everything from cutting edge models be open source to close ended and available by API use on kind of a per use charge. And I think really the consensus on the best way to do this is not yet decided. And so, just to highlight some really exciting work in this space, this is something I'm personally very excited about. There are a few global centers that are actually working on developing these transformer models for genomic data. ARC Institute is one, InstaDeep is another. And we at Mayo Clinic are doing this as well. And it's really exciting that there are multiple models that are actually open source for doing this. So Evo 2 is the latest one that's come out in a research paper from the ARC Institute. But importantly, these have not yet been translated into patient care. So in doing incredible things like generating plausible DNA sequences, new proteins, but bridging that gap to patient care is something that we still have to figure out. We are actually hoping to produce a proof of concept in rheumatoid arthritis. And we think this is a really exciting use case because, for anyone who isn't familiar, rheumatoid arthritis is a disease where the treatment progression is essentially trial and error. So you'll get put on a drug for probably 6 months while you try to see if that works for your rheumatoid arthritis. About 50% of people fail that and end up moving on to other drugs. But we suspect that there are some genomic signals that we could investigate with a large language model to see which patients would actually respond to this first line drug methotrexate versus others. And this will be our first proof of concept for how a model like this might actually be translated into patient care. And so this will actually involve patients electing to have their exome sequenced, run through an AI model, and see, what might be the best recommended treatment for them. There's also tons of opportunities to innovate in this space, whether that's on context length. So the latest generation of genomic LLMs have a context window of about 1 million base pairs, but of course, human genome is 3 billion base pairs. So figuring out how do you actually get all of that information into a model because maybe you're looking for interactions in chromosome 1 and 20 or something like that. There's also a lot to be done around interpretability, not just for genomic LLMs, but really for all LLMs. Thinking about when models produce unexpected outputs or even expected outputs, how is it actually arriving at that conclusion? And there may be interesting things that we can learn from that, or ways that we can evaluate appropriate or inappropriate situations to use these large language models. And of course, translation for to practice is something that we would love to see in clinical medicine as well. So backing things up a little bit from sort of the frontier large language models, we also have a number of AI models that we've developed that we have actually put into practice and even evaluated in prospective trials. So to walk through a few of those, we have an AI ECG model that was developed by our cardiology department, where they had a large database of ECGs, trained a computer vision model on those, and they've been able to demonstrate a number of different predictive capacities from that. But in one particular prospective trial, they actually showed that they could increase diagnosis rates of asymptomatic low ejection fraction and get patients appropriately referred, put on medications, or get ICDs or whatever it was that they needed. And that was by actually displaying this to hundreds of primary care physicians in a randomized way and seeing who ultimately, realized this diagnosis and ordered echoes for these patients. Building on some of the work that was presented earlier, we also have a palliative care AI model, which recommends for hospitalized patients who might be appropriate for palliative care consult who hasn't had one. And this actually showed that it not only increased the rates of palliative care consults in a prospective trial, but also decreased readmissions and cost. And so we're really excited to be moving forward on that with a third-party company to hopefully bring this outside of Mayo as well. And then one that I've worked on to kind of wrap this up is admission prediction module for emergency department patients. So trying to understand right when a patient shows up at the emergency department, what's their likelihood of needing to come into the hospital. Um, and it turns out that we can do that pretty accurately. And we completed a prospective trial on that. And it's looking like that actually reduced ED length of stay, which always makes the ED doctors quite pleased with their operation. So this is probably a scene that's familiar to anyone working in IT in the room. So historically, you've had to run all of your data infrastructure, all of your IT hardware and software on premise in rooms that look like this, or maybe scaled up by many times and magnitudes of messiness. Um, but of course, now there's opportunities to outsource all of that to cloud systems so that you can rent computing space, storage space, whatever it is that you need at lower costs, and be able to really democratize data and compute access across organizations. So this has been fantastic for us at Mayo Clinic. We are a Google Cloud customer, and that makes it easy for really anyone within our organization to access clinical data. And I'll cover that in a subsequent slide. But it's really a space where there have been a ton of industry advancements, whether you're talking about Amazon Web Services, Azure, Google Cloud Platform, Snowflake, others that have driven progress such that entire organizations can upload their data easily to the cloud, control access within the organization, rent GPUs to people. You can train models, build software, whatever it is that you want to do. There are, of course, risks of vendor lock-in, and so there are a lot of debates right now. Does it make sense to go with a single cloud for your organization or have kind of a multi-cloud setup? And then we've also noted that if you have an organization where historically everyone's been working in that type of server room that you saw at the beginning, um, people are going to need entirely new skill sets and new training in order to be able to work in a sort of cloud-centric organization. which, for us, thankfully, we've had great partnership with Google, and they've offered trainings to a number of our IT and clinical staff to do exactly that. So covering a little bit of what that looked like, we have copied all of our clinical data into Google Cloud Platform, made that available for pretty much anyone, all the way from a introductory medical student all the way up to our CEO. And they can get in, interact with that data, train models, build software. And we've actually used this for a number of different things, including data storage of all different types. We've hosted applications that are used in live production. And so this has been just a tremendous enabling partnership for Mayo Clinic. But of course, noting that it has required new skill sets for a number of people. But thankfully, these systems are really so large and mainstream at this point that there's huge amounts of documentation. There's training courses offered by the companies themselves, as well as places like Coursera, where you can absolutely find sources of information to upskill and get familiar with these. Just to give another example, this is just a sliver of what is offered through Amazon Web Services. I think probably covering every product that they have, numbers in the hundreds. But whether you're on Amazon, Google, or Microsoft, you'll see kind of a similar offering where there are tools for data storage, there's tools for training models, for deploying models, building software, controlling access, whatever it is that you need, really. And so this is kind of the scale of opportunities that are available by uh, using a cloud platform. And for anyone that wants to dive into this a little bit deeper in a clinical context, we also publish a brief report sort of describing what does the end-to-end process look like if you want to, um, if you have an idea for a model, you want to grab some retrospective data to train it. You then need to harmonize that against the live data feeds that you have. And then this ultimately describes deploying our model, our ED admission prediction model in our EHR's cloud runtime environment, and kind of all the different nuances and challenges that come with that. But it's become an increasingly common workflow for us at Mayo Clinic, and so I think a lot of people have appreciated having sort of a roadmap for how to do this. So, talking a little bit more about research, historically, of course, research has been driven by an investigator having a hypothesis, a question that they want to ask, and then going out and getting the right data for that, performing some analysis. But we're, of course, in an era now where, thanks to things like unsupervised learning, you can actually have insights suggested to you from sets of data rather than you having to ask a question yourself. And so, uh, whether that's working with a aggregated data set from something like Mayo Clinic Platform or others, there are now ways to sort of just say, I'm interested in maybe this disease state or this medication, and then systems can actually serve up insights to you related to that or patterns that might exist in data. And so this is really kind of a new paradigm for how research can work. We're, I think, in the very early stages of seeing this. We have some things that are kind of internally available to us at Mayo Clinic to work on for this type of use case. But I haven't seen a ton that's available in the market for kind of broader use. But again, I think sort of similar to having access to large data sets, the question again becomes, what are the insights that are meaningful to surface from this? And this is really an opportunity for clinicians to collaborate with data scientists, with software engineers, and think about, how do you get sort of the relevant and meaningful insights from this data? Because, I think if you just left this to sort of machine learning approaches or large language model approaches, you could get something like, here's a cohort of notes that says the lungs are clear. Here's a cohort that says that there's no crackles or rhonchi or wheezes. And I think to anyone with clinical knowledge, you would just assume that those are basically the same thing. And that's actually not really a meaningful insight. Coming back to the genomics example, there's actually some really interesting work that can come out of large language models and using interpretability approaches for this. So there are companies like Goodfire who are working to understand the inner workings of large language models, and you could do things like, if you see that a large language model can accurately predict whether, what drug a patient should take for their rheumatoid arthritis, can you actually reverse engineer that and see what about the patient's genome the model is looking at to make that conclusion? So that might be sort of validating the initial knowledge that you had. Maybe it's already been published that these genes contribute to methotrexate response. But it can also be hypothesis generating because this is the type of opportunity where a transformer model might actually pick up insights that we haven't had through conventional bench research and things like GWAS. Um, and so uh, I think interpretability is just one of the many approaches that you could have to sort of unearthing these insights from unsupervised learning. So coming up to the final example here, of course, we've historically expected patients to come to us for care. So whether that's in the hospital, in the clinic, often through sort of cumbersome or inconvenient scheduling processes. But of course, we don't need to do that anymore. At least for a variety of conditions, of course, spurred by COVID pandemic. Now we have things like telemedicine, we have things like wearables, and artificial intelligence. I think is a big opportunity in this space to design new biomarkers, patient-reported outcomes, and sort of derive insights in an automated way from the data that patients may be generating through these different means. So I think the benefits here are not really limited just to clinical care, but I think to research as well. Wearables, telemedicine are all a big part of things like decentralized clinical trials. And I think there are big opportunities to innovate in things like creating new ways of assessing patient outcomes that can be done in the convenience of a patient's home, be done rigorously and in ways that are validated the same as might be the case if a patient was coming into the office for a clinical trial, for instance. But to pull these things off, of course, there's a lot of integration that has to go on between different tech stacks in order to make this work. Oftentimes the EHR vendor is not the same company making the wearables or making the telemedicine platform, and getting all of that data into the same place so it can so you can work with it, analyze it in real time is no small challenge. Um, and a number of the business models that really thrived during COVID are now unfortunately challenged just because we sort of gone back to sort of normal state of affairs for healthcare in certain domains. So for one exciting example on this, we've launched a care at home model run out of our Florida campus, where there's actually a centralized hub for patients across Mayo Clinic who want to receive care at home. And this has been a huge undertaking because every locale that this operates in requires having some staff on the ground, requires different licensing requirements, regulatory frameworks. So these are, I think we're kind of in the early stages of seeing these roll out, but it's been something that is having impact in multiple states for Mayo Clinic, which is really exciting. On the other hand, you could look at something like this chart of what happened with Teladoc's stock price, and you could see a lot of promise and excitement around the time of COVID, which is really essentially petered out. And I think that this, unfortunately, tells a story of a number of companies that are in this space as well. Um, but rather than end on that note, I think there's a number of opportunities that to be excited about here. So there are a lot of different ways to engage. So, of course, you can build your own tools, whether that's building software, training models. But even if that's not available to you or something that you're interested in, just studying what's out in the market, getting a nuanced understanding of how these things actually work in clinical practice is really an opportunity in itself. Facilitating adoption of best in class solutions when you identify them. And, I think there's opportunities not only to be on the cutting edge of adopting what's coming out, but also use exercising judgment and not necessarily jumping at what is the latest and shiniest thing if there are 10 alternatives for that, and also waiting for sort of the market to sort itself out. And then one thing that I think has served me well and really is sort of just timeless is partnering people across disciplines and across different sets of expertise. Enables things that no one would be able to do in isolation. So just like you are doing, bringing together clinicians, data scientists, software engineers, this is where great things happen. And encourage you to do more of the same. So that's all I have. Yeah, take questions. If we are, it's not a huge investment that we're making. I'm not super familiar with that, but yeah, at least in kind of the AI spheres, it's not something that's come up. Yeah. Oh, what's our involvement in CRISPR and yeah, mRNA? Hmm. Yeah.
Thank you. So you were talking about the adoption of cloud services, and you suggested that one strategy is to consider splitting them among vendors. I'm curious if you would recommend, for instance, giving one radiology, the other lab, or whether you would actually duplicate those because to see how they manage that, and they all obviously are all backed up the wazoo. So I guess we're not terribly concerned about losing the data, but it's more a management of the data and how you interact with them, right?
Yeah, so that's a great question, and honestly, one that's a little bit outside of the work that I do. So that's probably something that's operating at the level of like our chief information officer. I don't know that I can advise you on exactly that point.
Hi, in your discussion of Evo 2, and you talked about some of the promise, obviously, of personalized medicine as a result of that. Can you, in your thinking, can you lay out some of the steps you think we would need to go through to go from where we are now to actually using that in patient care and some of the problems we might bump in because of that?
Yeah, absolutely. So, um, I think first thing is getting models that are purpose built for the right task. So, a big focus to date has been DNA sequence generation, which is sort of different than making predictions on patients, both in terms of the way that you take data in, how you train the model, and what you're expecting to get out of it. So I think that's one thing is really making sure that you have models that are purpose built for this clinical use case. Um, and then from there, it really becomes, I think, an entire software as a medical device exercise where you have to have some retrospective validation that's published and reviewed on that, then bring it forward into clinic, seeing what the outcome or impact on outcomes are. And so, really, I think it's kind of a multi-year timeline to do that, but following kind of the software as a medical device steps.
Can you describe the thought process at Mayo and how you advise other organizations around strategic prioritization of projects in different areas, especially large institutions like Mayo, with still limited resources and funding and time, as well as rollout fatigue?
Sure. Yeah, it's a great question. Um, So we have kind of taken the approach, I think, particularly over the last handful of years, of allowing more ground up efforts rather than strictly top down, sort of like defined priorities necessarily. So I think the way that we have approached things, which I personally favor, is really allowing groups to work on the problems that are interesting and relevant for them. And up to a point where essentially you're then talking about deploying this into actual patient care, in which case then you have to go through a rigorous governance committee, including representation across all of Mayo Clinic, thinking through how does this actually fit in the portfolio of solutions that are out there. um, but prior to that, really allowing for open experimentation and just giving people the tools to do that. So I think that can be an effective approach, and I think it's one that, for the people who are doing that, find pretty exciting.
Hi, first of all, thank you for your time. A lot of health systems they're trying a lot of different things and they run into this chasm of how do I actually put this into production and have my people start using it. Obviously, you guys have done a lot. What's been, apart from HIPAA and adoption, what's been some of your top tips to get over that chasm and actually put some of these things in people's hands?
So I think there is a lot of opportunity to basically lean on uh, vendors of different tools, and also, for things that are internally built, expect a higher standard of essentially user onboarding. So we see oftentimes, like sort of the standard operating procedure for things is maybe you have a PDF document that tells you how to do it. Maybe you have to watch a video to understand how to use a tool. When really we should be aiming more for like, iPhone, iOS standard of adoption, where it's just easy enough that you can pick it up and start using it. So I think that's really a large opportunity to, expect more from people who are developing these types of tools, and sort of rethink how we've historically approached adoption rather than like a um, institutional change management process, which of course is still part of it. I think it can also be a product side challenge as well.
Thank you again, Dr. Ryu. We really enjoyed that.